My name is Amanda Robluski. I'm a licensed clinical social worker at Boulder Community Health. I coordinate what's called the PILLAR program, and PILLAR exists to help get people connected to care for management of substance use disorders, wherever they fit into the continuum, and when they're ready to access treatment, we are ready to help them get to the right place, hopefully at the right time. So this is a series called Ask an Expert. Once again, I'm so grateful for everybody that's joined us live, both online and in studio, or if you're watching the recording, thank you so much for being willing to learn and find out more about the topics we talk about in this series. That being said, they're usually pretty big topics. They're pretty heavy subjects. Tonight, we are going to be discussing involuntary substance use disorder treatment, which is a really big subject, and like with most things on Ask an Expert, it's something we don't talk about enough. So I'm thrilled that we've got Dr. Nadia Haddad with us to walk us through what it is, what does this look like, how do we access it here in Colorado. I'm sure it varies state to state, but in Colorado, this will be a Colorado-specific discussion, but it's still very valuable and relevant for anybody who is seeking care potentially. A little bit of housekeeping. We have a chat online, so please feel free to ask questions, engage with the speaker. I will be the disembodied voice facilitating the discussion throughout the evening, and please chime in, but understand that we're not going to have all of the answers tonight. This is an introduction to this topic, and it's hopefully a starting place. Like everything with Ask an Expert, we're also hoping to instill hope and remind people that recovery is possible, treatment is out there. There is a huge community waiting with open arms for the people that are ready to be a part of it. So give us just 1 second. We'll have Dr. Haddad back in the seat in just a moment, and we will get started. Thank you all so much.
Are you going to tell me when to just get going?
Yep.
Just get going.
When you're ready, jump right in.
All right. I'm just going to get myself situated here. Hello, everyone. My name's Nadia Haddad. I'm a physician. I'm a board-certified psychiatrist, also board-certified in addiction medicine. I am thrilled to be here. Thank you so much for coming, for having me. We are going to be talking, as Amanda had just said, about involuntary substance use disorder treatments in Colorado. So I'm just going to launch on in and see where we get. Okay, so in Colorado, involuntary substance use disorder treatment is governed by two Colorado revised statutes. So it is the 2781-111 and the 2781-112. Those are the emergency commitments and involuntary commitments. So I want to say right from the start, this is coming from practical experience. This is not legal advice. I am a psychiatrist. I'm not a lawyer. I was medical director for the local approved treatment facility, which we will get to in a little bit. And I did that for 3 years. I performed physician certifications, which you'll learn about a little bit later. And I supported patients and families through this process. So I'm going to do my best to let you know what I've experienced in this process, help you navigate this process a little bit. But if you want official answers and guidance, please contact an attorney or the Behavioral Health Administration. The next thing I wanted to say is that there are parallels here with the mental health involuntary treatment process. So for those of you who are familiar with that, there are notable similarities and notable differences. I'll try to call them out as we go along, and if you have questions along the way, please feel free. Okay, so I wanted to start just level setting. Substance use disorders, that's the newer term that we use. It's also known as, and people will use the term, addiction. So what is it? It's continuing to use despite negative consequences. It's categorized as mild, moderate, or severe. So I wanted to start with some myths that we have about substance use disorders. I hear these a lot in various settings, both with the general public, but also with treatment professionals. So I just wanted to call out, like, one thing that people like to say is, well, someone isn't motivated enough to seek treatment. Internal motivation is necessary to the benefits, to get benefits from treatment. And I want to say right now that in the midst of active substance use disorders, many people don't have a lot of motivation, and they express significant ambivalence. There will always be reasons not to use and reasons to use, otherwise people wouldn't be continuing to use. The other big myth I hear a lot is people need to hit rock bottom before they will seek help. And the corollary of that, if you think about it, is if they're not seeking help, well, they haven't hit rock bottom yet. And we'll wait around and see if they hit rock bottom. So having been overseeing the community mental health center's addiction treatment program, I will tell you that some people hit rock bottom and they keep using. And they lose their jobs, they lose their family, they lose their dignity, they lose their homes, and they continue to use. So when we're talking about this process, there is, I want to hold space for the idea that even if someone isn't internally motivated, there is hope. Even if someone appears to be ambivalent, even if they say, okay, I kind of want to quit, but they don't seem to be able to take the steps to do so, it doesn't mean that they aren't worthy of treatment, that they aren't capable of engaging in some level of care. So, and then the other level setting I wanted to do for today is to really put out there that adults have the right to make quote unquote bad choices. So we wouldn't all in the same circumstances make the same choices, right? And at the end of the day, just because it's a substance use disorder, so meaning just because there are negative consequences to what is happening for somebody with their substance use, it doesn't mean that a treating provider or the legal system can intervene. We can't restrict rights, we can't mandate treatment just because people are making choices that we wouldn't make. So when we're talking today about mandating treatment and involuntary treatment, we're talking about a very specific sliver of the population who are experiencing severe substance use disorders. And of the population who experience severe substance use disorder, this is an even smaller subset of that population. And we'll talk about what that means and who would meet these criteria, but it's not just use, it's not just problematic use, it's not just severe substance use. It's an even smaller subset than that. Okay, so the first part of this process is called the emergency commitment. And that is, so I'm going to call it an EC sometimes, so that's why I put that there on the slide. So this is directly from the BHA's website. So when a person is under the influence of or incapacitated by substances and clearly dangerous to the health and safety of himself, herself, or others, they will meet potentially criteria for an emergency commitment. And we're going to break apart these pieces in a moment. But I want to point out, so obviously it has to have substance related, right? That's the under the influence or incapacitated by substances. and there must be clear dangerousness. So we'll talk about what that means, and you're going to see this both in the EC, the emergency commitment pieces, and then later we're going to talk about involuntary commitments, and you'll see parallels here with the mental health involuntary treatment laws, because the way that one way that I think about this, right, is that dangerousness to themselves or to others is a parallel, right? We call that, for short in the community, we'll call that DTO or DTS, and you'll see that there. Danger to others, dangers to self. Or incapacitated, which I think about as having a parallel with grave disability in the mental health treatment laws. And so when we think about involuntary treatment across the board, whether it's mental health or substance use related, we have to really think about the fact that it needs to meet dangerousness criteria, and that if you're more familiar with the mental health laws, it is parallel. It is danger to self, danger to others, grave disability in mental health, or incapacitation in the substance use disorder. And in an emergency commitment, this is involuntary treatment for up to 5 days in an approved treatment facility. So again, a parallel here. In our M1, our mental health holds, we have up to 72 hours. In the emergency commitments, it's up to 5 days. So I'm going to get into the weeds here, because I'm sure there's some people either in this room, watching at home, watching later on, that will want to know some of the weeds as it relates to this. So it is a bit complicated. And here's where some of the parallels start to diverge, okay, between the mental health involuntary treatment laws and the substance use disorder treatment laws. So in an emergency commitment, the written application is done by a responsible person. So this is somebody 18 years of age or older. And then this is to the administrator of an approved treatment facility. So if we think about this for a moment, this means anyone with knowledge of the circumstances who is 18 years of age or older can write an emergency commitment according to statute. This is different than an M1 hold, where we have certain licensed professionals, certain first responders who can write M1 holds. So as what I think of as sort of a stopgap measure, the emergency commitment is not valid unless it is approved by the administrator of the treatment facility. Okay, so this starts to get really complicated. In practice, we don't have like random people on the streets typically writing emergency commitments and then like petitioning for the administrator at the approved treatment facility to do it. In practice, what I've seen is that it's typically first responders, police, EMTs that are writing these, or once they get to a detox facility, so one of these approved treatment facilities, a staff member is writing an emergency commitment. That's where I typically see this used, but this is what the statutes say. And then the administrator can choose to approve or not, so they understand what the criteria are. Does this meet dangerousness criteria or not? Are they incapacitated by substances or not, and choose to uphold it or not? So it's not valid unless the administrator approves it. And then if it's approved, that person remains within that approved treatment facility. Okay, so I'm going to parallel this with involuntary commitments. So an involuntary commitment is treatment for up to 270 days. So if you're doing the math in your head, that's 9 months, up to 9 months of treatment. And it's for folks who are medically and psychiatrically stable enough and refuse or have demonstrated an inability to remain in voluntary treatment. So those pieces are important as we're thinking about who we should think about for involuntary commitments. It's not just someone who meets the dangerousness criteria, because we always, just like in the mental health laws, we always want to offer people the least restrictive option possible. We want to give people autonomy. We want people to have choice. And so we want to offer voluntary treatment if at all possible. So this is for people who have a track record of refusing voluntary treatment or being unable to complete and participate in, remain in voluntary treatment. And then the person will go under the custody of the BHA. So I want to talk about some practice.
Sorry, Dr. Haddad,
Yeah.
what is the BHA?
The Behavioral Health Administration. So this is the new Colorado State Department that used to be the Office of Behavioral Health, or the OBH, and became the BHA fairly recently, in the last couple of years. So they oversee the mental health and the substance use disorder involuntary treatment pieces. Yes. Okay, so practically speaking, I bring up these points not because you need to memorize them, they're like check boxes, but again, it is a certain sliver of the population that meets these criteria, because typically what I see happen is one or the other, and it's typically actually one extreme with substance use disorders. I think because what I have noticed, at least in our own community, is that there's not a lot of familiarity with the EC, IC related statutes, and we don't sort of act on them very often, that typically what happens is someone is so severely ill from substance use disorder. So these are the people that we are seeing. By the way, I realized as I was talking that I completely neglected to explain what I'm doing these days. I said that I was doing, that I used to be the medical director of the local community mental health center, which is the approved treatment facility in Boulder County. But right now, I'm at Boulder Community Health since December, and I am overseeing the Department of Behavioral Health there. So I do a lot of different things clinically at Boulder Community, including rounding on our Foothills consult service, so that's in our med-surg hospital, seeing folks who are so incredibly severely medically ill from substance use disorders that they are detoxing in the ICU. They have medical complications of substance use disorders like severe cirrhosis and so on. And then many other things around Boulder Community. So I just wanted to put that out there before I continued. So going back to this, what I have noticed is that people tend, because we are not familiar so much in this community with ECs and ICs, that people tend to get to a place of such severe illness that they, in many cases, they've surpassed meeting criteria for an involuntary commitment. And what I mean by that is, if someone is so incredibly medically ill that they can't actually be safely in a treatment program, then they can't go through the involuntary treatment process because it requires them to go to a substance use disorder treatment program. If someone is so psychiatrically ill, so I'll give you an example, people who are using methamphetamine daily, consistently for many months to years will develop sometimes a pretty severe psychotic disorder that persists. And even when they stop methamphetamine, they're very, very severely psychiatrically ill, to the point that they are gravely disabled for mental health reasons. They're severely paranoid. They're not eating. They believe people are stalking them. They're out to get them. They're fleeing treatment programs because they believe that the treatment providers are out to get them, and so on. If someone is so psychiatrically ill, even from their substance use disorder, that they can't participate in treatment, then again, they've sort of gone past this involuntary commitment realm, and this isn't the right treatment for them, or this isn't the right path to go down for them. So that's why the medically and psychiatrically stable enough is important, because we have to think about where we're sending them to and whether they're capable of participating in and benefiting from treatment at that stage. Another example I'll give is that sometimes people have been drinking so heavily for so long that they develop Wernicke-Korsakoff syndrome, which is among other symptoms that people get, they can get a almost like a dementia process where they're not laying down memories and they can't really remember from one moment to next what's happening. And if that's they can't really participate in treatment and benefit from treatment. So these are the considerations that we need to think about as we think about whether someone should be going down the route of an involuntary commitment. And then let me move on here. Okay. And so I wanted to talk a little bit about this involuntary commitment application because there's multiple parts to the involuntary commitment process, as there should be. Anytime we are taking away someone's rights, there should be checks and balances. And anytime we're taking away their rights for potentially up to 9 months, we need to really be putting a lot of thought into whether they meet the criteria that we need them to meet. And so this, again, is a responsible person over the age of 18 who petitions the court, and there's an application process on the BHA website. There's a literal application you can download. And basically you're answering questions on this application that's attesting to the fact that the person has a substance use disorder and that the person threatened or attempted to inflict or inflicted physical harm on themselves or another. So that's that DTS, DTO criteria. Or the person is incapacitated by substances. Okay? So I put a little screenshot of one page of this application here, or part of the page. The IC application is 17 questions and 4 pages, and it's quite lengthy. So meaning, when you go in there, there's a lot of detailed information, dates of attempted treatment, dates of events that happened that one feels they've met these criteria, and so on and so forth. So when I read them as a physician certifier, sometimes they're upwards of 10, 15 pages, depending on what people have written in all of this.
And Dr. Haddad, just so the process is clear, is the emergency commitment the first step to filling out?
I'm going to get there. I'm going to show you a little. Yeah, that's a great question. I'm going to get there in just a moment, and I'll show you the whole process. But
Perfect.
Yes,
thank you.
Absolutely. Okay, so the elements of an IC is that you've got to have that application in by this responsible person. So typically what I see is a family member, a loved one of some kind who's filling out this application. But I want to be clear that this can be any interested party who's trying to support the person. So sometimes I've seen a housing case manager who's written the IC application because they're watching their client become sicker and sicker, right? I've seen a police officer actually take the time to fill out this entire IC application because they're being called repeatedly, going into someone's house and seeing what's happening to them in their own home.
We've got a question online, actually, that's in that vein. They're wondering if you can a little further define incapacitated.
So it's not really defined to my knowledge. Again, not a lawyer, but I don't see it defined so much. And I think in some ways, my interpretation of this is similar to grave disability in that I think in some ways it's intentionally meant to be vague. Mm-hmm. So when I think about incapacitation, and again, please contact a lawyer or the BHA if you want more details, but when I think about incapacitation, I think about the fact, so one clear case of incapacitation would be if someone in the emergency commitment setting is so intoxicated that they can't walk, they can't see straight, they're stumbling into traffic. That would be incapacitation from intoxication. So it is unable to care for oneself as a result of intoxication or the sequela of intoxication. That's how I think of it.
Thank you.
Yeah. So was there?
No, just looking back, seeing if there's any questions from the audience, just, giving people the opportunity.
Oh, can we ask if they go?
Yes, please. Yeah.
So maybe you'll answer this later, but I have spoken with local psychiatrists, and don't think all of them know that 2 years ago how much things changed as far as this involuntary admission. And so I, at some point, would love to be able to share with my colleagues that when there was incapacitation, in this case it was so much marijuana that it had changed the signaling of the brain, and that the psychiatric meds were no longer working as well, and the psychiatrist could not get a stable mood, and the parents were very, very frightened for this dangerous person. And when the psychiatrist, the local psychiatrist, asked for help and to help start the process, there was a lot of the people that went, the police and the social worker, they wouldn't carry through. So I was just wondering what that might have been about.
So the question from the audience was, in a previous instance, the professionals on scene, so law enforcement and mental health, were hesitant to go through with writing, it sounds like, at least an emergency commitment. And I think the question in that is, like, why would that hesitation exist when there's this opportunity to maybe provide that person some access to care? Does that sum it up?
That sounds good.
Perfect.
So, I mean, that's a hard question, right? Because at the end of the day, anyone can write the emergency commitment. It's really about, there's a couple of logistical hurdles with emergency commitments that feel a little bit different than M1 holds. And even with M1 holds, we're struggling with that too. That's the mental health involuntary hold. With emergency commitments, if a person isn't at the detox facility, then how are we transporting them to the detox facility? So my experience has been, and I think for good reason, our law enforcement colleagues are often asked to do these transports, and they have to make their own choices about whether or not it is reasonable for them, for lots of different reasons, for them to do so. I don't typically see it successful as of this point. I haven't seen it be successful that, let's say, a family member writes an emergency commitment, calls police and says, come pick up, I put this person on an emergency commitment, and then the police are like, okay, no problem, and I'll take them over. I don't see that's what's happening in practice. So I think one logistical hurdle is usually someone has to be at the detox facility already to go on an emergency commitment, or else police or EMTs or whoever have to have been called to see that person when they're actively creating a disturbance or picking them up from a DUI or whatever else, to then bring them to the detox facility on an emergency commitment. So I don't know that that answers your question, except that I think the logistics of the emergency commitment and the M1 hold, right? You know, that transport piece is challenging, and it's also a question of whether they met the criteria or not. That's hard to know.
Thank you.
Yeah. Okay, so back to this involuntary commitment. So I just want to point out again, this is a complex process, and there are 3 important components to the IC process. Number 1 is that long application that requires a lot of thought and someone who's very engaged to fill out. There is a physician certification. So, and that's a physician, it's called out physician, not just a psychiatric professional. So a physician needs to evaluate and attest to the fact that the person meets criteria. And then there needs to be, back to that earlier question, an active emergency commitment. So I hope it's this one. Here it is. Here's the slide I was hoping to get to answer your question, whoever asked this online. So the involuntary commitment process requires an EC first. So that's at the licensed detox facility, up to 5 days. An IC application needs to be filed with the BHA, the Behavioral Health Administration. So that's downloading the application from the website, filling out the 17 questions, 4 pages adequately, and submitting it to the BHA. The BHA then communicates with the licensed detox facility and says, hey, we've got an IC application in. Can you get a physician to do a certification? And so this is where I would come in, and a physician certification is performed while the person is at the detox facility. And so this isn't like family member needs to find a physician to go down there. This is somebody that the detox facility figures out a way to get a physician there to do this. This then goes through the court process. And then there's a final determination of whether this person is actually meeting criteria and the court believes should be on an IC or not. And then a person can stipulate along the way, so meaning a person who has an IC application filed for them can just say, okay, that's fine. Let's not go through this whole court process. Just place me in treatment. So what happens after an involuntary commitment? Well, so I said it's up to 9 months of mandated treatment, but I want to be clear here, there are no locked facilities in the state. That is a requirement of Colorado law. We cannot have locked substance use disorder residential facilities. So as a result, this also plays in, because if someone is absolutely committed to not participating in the involuntary commitment, and they keep eloping from facilities, the BHA can ask police to go get this person and so on. But again, there's practicality considerations here, right? The police tend to not want to break down a person's door if someone's in their own home, and to gather them up to bring them back to a facility, right? So the fact that there are no locked facilities plays into this process, and typically what our hope is that once you get somebody out of active use for a period of time, that they can start making a different decision about engaging in treatment. And sometimes the hardest part is just getting them out of active use so that they can start having a little bit of insight, a little bit of motivation, a little bit of engagement in the process. And typically what happens in terms of treatment for these is it's stepping down treatment. So typically a person will, the BHA will ask that a person starts at a residential level of care, and there's a couple of different residential level options that people can be at, and then they'll step them down the continuum. So from detox, which is that first step in the emergency commitment, to a residential level of care, then to an intensive outpatient level of care, and then to an outpatient level of care, with the idea in mind that someone, we're trying to get somebody to a place where they're more and more independent with their recovery, so that by the time the involuntary commitment process is over, they have their own recovery supports, they're active and supported. And I've seen this process go really, really well. And I've also seen us have to do this process multiple times on the same person, meaning either someone starts this process and then elopes, and then the BHA drops the involuntary commitment, and then they end up back in the same circumstances again, which often happens with people who are struggling with active, severe substance use. And then the process gets started again, and then they elope again, and maybe third time's a charm. Or I've seen people go through this whole process, 9 months, through involuntary treatment, stepping down, doing great. And then when the accountability of the involuntary commitment goes away, pretty quickly relapse, get back to the same place again, and eventually need to go through this process again. And I've seen people be incredibly successful the second time they go through it, right? So just like if we think about our justice involved folks who have probation and have, urine drug screens, oftentimes when I've engaged treating folks who are involved in probation and so on, they will say to me very, very directly, like, I'm worried about what happens when I no longer have the accountability of the urine drug screens, right? So there is some containment in this process that can actually feel supportive, but it's also frustrating for people too to be, forced into treatment. So there's a lot of considerations here.
May I ask a quick question on that? So, like if we're doing insurance and we're asking for, so they'll pay, we're doing concurrent reviews. And so treatment's not going to last forever. I'm curious about the involuntary commitment. Once that's in place, is it ever reviewed and potentially dropped before the 270 days is up? I'm just kind of wondering about what that process looks like once the IC is in place.
Yeah, so just for folks online that may not have heard all that, the question is around payer source and if these involuntary commitments are reviewed regularly by the BHA, like treatment generally is by insurance companies, and what does that look like? What is the funding source, and is it ever potentially dropped?
So this might be more in the weeds than I'm able to answer. I think what I can speak to is what I have seen is that regardless of the ability to pay or having a payer source, so people who are unhoused and uninsured still can go through this process. So who pays for it and how and all of that is above my pay grade. But it's not like, oh, you've got to have really good insurance in order to go through this process. The other question is it reviewed? And the BHA is, what I have noticed of the IC coordinators who are actively involved in this is that they're very actively involved in this process. So they have a handful of folks in each of their counties who are going through this process. This isn't like hundreds of people typically, and they are interacting with the treatment facilities, figuring out how people are doing. Are they ready to step down? Okay, they're ready to step down, and so on. Oh no, they're not. They're relapsing. Do we need to put them back up at a higher level of care again? And I've been involved in many a treatment team conversation with the IC coordinators around, what is the next step and what should we be doing for this process. So, and typically what I have seen, and this is again where I'm a psychiatrist and not like at the BHA or an attorney in all of this, but typically what I've seen is that we aren't always going for all 9 months when we start this. Sometimes it's a 3-month period of time that we start with and see how people are doing and go from there. So I think it's flexible is my experience so far with it.
Thank you.
Yeah.
And just to do a time check real quick, because we got started a little late, if everyone's cool staying a little late, we'll go the full hour. It's about 5 minutes to 7, so just check it in, being mindful of everyone's time. Thank you, everybody.
Okay, so I wanted to compare and contrast here. I wasn't sure where to put this. Maybe I should have put it at the beginning. But if we compare and contrast this process, the emergency commitment is up to 5 days. The involuntary commitment is up to 9 months. The criteria are the same. It's danger to self, danger to others, incapacitation, either way. For an emergency commitment, they need to meet criteria. And then I should have put also here, and be at a designated, detox facility, because getting them there is a challenge. And in an involuntary commitment, they need to meet criteria, but they also need to have an active EC. They need to be refusing treatment or have a demonstrated history of inability to really engage in treatment. And they have to be capable of participating. The typical use, when I have seen it, and again, this is my experience, I often see emergency commitments used for intoxication holds. So this is the DUI that's not safe, and they need to, go to a facility for a bit to sober up. The drunken college student after the game, who is unsafe, meandering about, passed out, whatever it is, and the police bring them over and put them on an emergency commitment. Someone screaming and yelling, an unhoused person screaming and yelling, intoxicated, maybe on meth, and needs to be have a space to let the methamphetamine go out of their system, sleep it off a little bit. That's how I often see emergency commitments being used, at least in this county. And then involuntary commitments is really severe, serious medical illness, repeated overdoses, like really severe sequela of substance use disorders. So this is being able to show in some way danger to self. So that's the cirrhosis, and someone's continuing to drink, and or they're dropping a ton of weight and not eating, and so on and so forth, or they're overdosing because they can't stop using. This is where we start to be able to show a pattern of like severe danger to self, or when they get intoxicated, they're pulling a gun on people, they're pulling a knife on people, they're whatever, right? So they're driving intoxicated with their kid in the car, and that starts to be a danger to others issue as well. So, but this is really like quite a high bar is how I see this used. And again, it's administered by an approved treatment facility in the emergency commitment and the Behavioral Health Administration. They oversee all this process, but directly the Behavioral Health Administration in the involuntary commitment. So I want to circle back to what I said in the beginning, right? Adults have a right to make bad choices. And I'm saying bad choices as in like, bad choices are bad in the eye of the beholder is the way that we approach this in a lot of ways. And I think some important tenets that that I use as someone who's engaging with people and trying to help people who have severe substance use disorders is that it's not for me to judge at the end of the day, right? Like even if somebody is having a severe sequela of their substance use, if they don't meet these criteria, like imminent dangerousness, imminent incapacitation, and so on, I'm not helpful to them if I'm giving them a bunch of judgment and thinking to myself like, oh, that's not something I would want for myself or for my kid or whatever, right? At the end of the day, your choices are your choices. Somebody can come in, say, I'm ready to go through detox. 6 hours later, say, I don't want to detox. I want to go use. Okay, we're here when you're ready, right? So at the end of the day, adults do have the right, and I very much hold this, to make a choice that I wouldn't make, that I wouldn't want for my loved one, that I think is a bad choice that's leading to severe complications for them and sequela for them. So to go through this process, that substance use disorder must also meet dangerousness. So they need to have a significant danger to others or themselves. It must meet imminence. So that danger is happening or is likely to happen at any moment. We have to be able to point to that. It's not just like, oh, I see this down the road, it's going to be really severe, right? They have to refuse or be unable to remain in treatment, and they need to be stable enough to participate in treatment. Those are the pieces here, okay? So adults have autonomy, so it's the imminence and dangerousness. So I just repeated myself a bunch of times. Here we go.
That's okay. It'll stick if you hear it more often. We have a question online asking if emergency commitments involve the police. Does applying for someone to go on an IC have legal consequences?
Like the way that a short-term certification, like is that what we're sort of talking about?
Maybe. I wonder if it's like a similar question, like line of thinking around that question.
I mean, it's definitely a court process. I mean, if we're thinking about like, can someone then get have their right to purchase a firearm taken away? I actually don't know the answer to that question. I know that's true potentially for certifications on the mental health side. I don't know the answer to that. I'm sorry.
Thank you.
We have a couple questions back.
I'm curious to know, so I think I heard you say that for the IC, you have to be in an EC. So does that mean the whole process of finding the physician and going to the court takes place in 5 days?
So, sorry, just real quick for those people online. The question is, since the EC precedes the IC and it's a 5-day hold, does this whole process have to happen within that 5 days to get somebody on an involuntary commitment?
So a good part of this process must happen within the 5 days. So that IC application needs to be submitted within that 5 days, and typically best submitted earlier in that 5 days, because then the BHA needs to come back and say, we need a physician certification. The facility needs to find a physician to do the certification if they don't already have one, and then the certification needs to happen. Now, does the court process need to happen within 5 days? No, they become pending IC from there, and then they try to facilitate that process as quickly as possible. But at that point, you have to get the physician certification and the IC application in within that 5 days and have the process started.
And then that person has to stay in the EC for the extended time while they're pending.
Right.
Yeah, and the question is just a clarifying one of the person that's on the EC then stays on that emergency commitment throughout that process.
Again, I don't know if legally they stay on the emergency commitment, or is it a pending involuntary commitment. I'm not sure technically what they are on, but they do remain in that legal status in the approved treatment facility, awaiting this process to move forward.
I have a question. How does a person know which treatment centers are approved treatment centers?
I'm
for
so
EC?
glad you asked that.
So for those of you online, the question is, how do you know what is an approved treatment center for somebody to be at for these emergency commitments?
What a wonderful question. So I put this forward. So it's harder than one might want. I went online and I clicked on, so it's often the community mental health center. So I'll say that if they have a detox. Now, what I did is I went on the BHA's website, because they've been beefing up a lot of their website content and a lot of their coordination services online. And there's a link that says like how to find an approved treatment facility. And then it took me to this section where I was supposed to put in what zip code I was in and what I was looking for. And then it didn't really clarify that it was an EC facility. It listed BCH, which is not one. It listed a bunch of other places. And so I was like, so my recommendation for anyone who's looking for more information on this or looking to find the one in their local area is to call or email the BHA. I think that's the best way for you to figure out where to go. And so that's the information that I've put up there. And they are not a 24-hour service, that is true, so they will get back to you. They are very engaged in this, but it's not going to be necessarily right away. And you can also get more information. I keep putting up the website where I pulled a lot of this information, because all of this information, besides my own anecdotes of kind of how the process has gone, is on the BHA's website. They have a very clear page that talks about emergency commitments, involuntary commitments, gives you the links to the applications, and so on and so forth.
Great.
There's another question.
Oh, yes.
Well, actually, my question is kind of similar along the lines of what Taylor asked, related to the approved treatment facilities. And I should preface it by confessing that I have been a bit of a skeptic around the ICEC, because I've seen a lot of data around worse outcomes after involuntary commitments, like twofold risk of fatal overdose and 100% return to use and drinking. And I also worry about some of the judicial equity, about like the vulnerable, disadvantaged population being more likely to not have that go in their favor. But my question, because I also try to look at the literature about good outcomes, and one of the things I've found is people who do better when it comes to opioid use disorder is if they're discharged on an opioid agonist medication like Suboxone or methadone. So my question was more about if patients at an involuntary treatment at an approved facility, are these approved facilities where patients might stay in residential, doing best practices and doing evidence-based medicine? I know there's a lot of facilities out there, residential in particular, where they don't allow patients to be on Suboxone or methadone. So I'm wondering, when the state's involved and they're mandating treatment, is it a facility that will treat for example, opioid use disorder by evidence-based practices.
So to summarize, that question was about being on medication for, what are we calling it now? Not MAT anymore, I'm sorry.
I was just saying like medication for opioid use disorder.
Okay, so specifically medication for opioid use disorder, something like methadone or Suboxone, are the residential facilities allowing people on the involuntary commitments to be on or stay on those medications when generally some of the residential treatment facilities don't allow MAT at all.
Sometimes.
Right. That's the question, right? So, okay, just want to make sure I summarized correctly.
So, Dr. Cushing, you're speaking my language. I actually submitted, well, fingers crossed, a colleague and I are wanting to actually do a talk on this for a conference coming up, and we'll see what happens. But we did a deep dive into the involuntary substance use disorder treatment literature and found it extremely lacking. And so I think part of the issue here is exactly what you're outlining, is that when we see outcomes for involuntary treatment that are so negative, and you start digging in, you start seeing that they're not at facilities sometimes that do evidence-based practices. They don't have access to medications for alcohol use disorder, medications for opioid use disorder, and so on and so forth. And so to answer your question, I don't know all the facilities that the BHA utilizes or what their criteria are. I do agree with you that they should be evidence-based, that we should be offering best practices. And I do think that with best practices, we may see different outcomes.
I hope so. Great. So we've got about 10 more minutes. Do we have questions in the room or online?
I had a question about the EC and the IC. So if you have, I don't know how often the ECs are used, but each person that may have an EC completed and they have the 5 days, they don't necessarily end up with an IC also.
Very, very small percentage of people on ECs end up on ICs.
Yeah, great.
Yeah.
That
Really being used more often than ECs are. Than
Oh, yeah,
yeah.
absolutely.
So, yes, that was the question. If somebody is on an EC in a facility, is it inevitable that they will end up on an IC? And the answer is most likely no, they don't. More often it happens that they do not, that the involuntary commitment process does not happen past the EC.
Yeah. I want to go back actually to Dr. Cushing's question because I think one piece that I want to point out is this is why I think it's important for involuntary treatment to have such a high bar, because I think at the end of the day, what reassures me is that on the folks that I do support through this process, if I don't do it, they are dying in the next couple of days. Do you know what I mean? Like, that's what I'm looking at. And so to me, it's like I'm giving them a chance at making a different choice. And I can't tell you how many times that I've seen, this is my hopefulness in this process, is that, I ran a hospital unit that does dual diagnosis, meaning mental health and substance use disorder, detoxes, M1 holds for people who were trying to end their lives when they were suicidal, or so on and so forth. And I would have people come in and say to me, I was drunk last night. That's why I tried to kill myself. Now I'm not suicidal anymore. And after seeing people repeatedly over and over again, what I have noticed is that even just the 3 days that someone's on an M1 hold for that can make a huge difference in somebody's life, a huge difference in somebody's ability to be like, oh, I've had 2 days away from substances, and now I'm starting to reflect that maybe I should go into treatment. Like, I do want to engage with my kids again. I do want to have a life again. But when I'm in the throes of addiction, I can't, make that decision. And so I think back to that point, I want evidence. I want us to do a good job figuring out whether this is helpful or not. And I also think there needs to be a really, really high bar, because at the end of the day, in my mind, I'm giving someone a little bit of space to make a different choice. And otherwise they will potentially be dead.
Okay, I think we've got time for maybe one more question. Did we have one more in the room? Yeah.
Thank you so much. This was very helpful. You talked about the dangerousness and the imminence of the danger, and of course that's really difficult to predict. And what if, let's say the people in the earlier question didn't get picked up, and they didn't get transported somewhere, and then they escalated and got very dangerous, and they, let's say, killed someone. Then where does it? I know you're not a lawyer, but how? What happens then? Who gets pulled into a potential suit that this person should have been picked up and taken and gotten some help, and but they weren't? So that whole issue of the seriousness of where it can go.
That is actually really similar to the question that just popped up online too. So that's pretty awesome. But yeah, in that same vein, what happens if, the possible harm seems imminent, but then the person then denies it when you involve law enforcement? Yeah, or, they have that little bit of clarity and then denies those things. Or, yeah, something happens, and is there liability involved, potentially?
These are wonderful questions and very hard questions for me as a non-lawyer. I mean, I think as a physician, what I would say is there's always liability involved. You know what I mean? Like, I think the way that I approach it is that we all just need to do the best we possibly can for each person who's in front of us and make the best possible choice that we can, knowing that we don't have crystal balls, right? People will come in and say they're not suicidal, and leave and end their life. And, at the end of the day, we do the best we can. So meaning, I don't know how to answer who's liable, and I think that's what a court decides right at the end of the day. If we pull, typically when people end up doing lawsuits around things like this, they include every single person that could possibly be included. So my practice is just to do the best that I can.
Yeah, case by case. I hope that answers the question online too, that you do the best you can with the information you have at the time as well.
And you document well, and
Yep. Awesome. Okay.
Are there legal consequences for somebody who's on an involuntary commitment who just continues to elope and doesn't comply? I mean, I think I heard you say earlier that it's really the motivation of the law enforcement to go pick them up. But are there actual legal consequences, like, well, you're going to spend some time in jail, or you're going to go to a locked facility, or...
So the question is, are there legal consequences if somebody is on an involuntary commitment and continually elopes from treatment? Is there possible repercussion of jail time or something like that?
I mean, I'm not absolutely certain. I would say that in practice, I've never seen that happen. I think that the frame that I've always seen the IC coordinators use is one of, we're here to help, right? Like putting somebody in jail is not a helpful intervention for most people. And so I've never seen that happen. Typically, they just drop the IC. They're like, well, I mean, not the first time, but if this repeatedly happens, they're like, this is not the right process for this person. That's what I've seen happen.
So with that, we are just about at time. Hang with us online just for a minute. We're going to pull up a slide that has a QR code on it. Please, 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 please take our survey. It takes like 2 minutes. It's really wonderful data to show our funders, because all of this is made possible through funds through our grants with the City of Boulder, so I want to thank them. I want to thank Stone Cottage Studios for hosting us again. We love it. It's always so fun and different and fabulous here. I want to thank everybody online and in person. I'm sorry, there's one last question we didn't get to, but I'll also put my contact info in the chat and the Pillar website, so please reach out and we can try to get some more information out there. And a huge thank you to Dr. Haddad for talking about this, for enlightening us, and hopefully encouraging people to put this in place when someone they know is really struggling and just can't access the care themselves.
Thank you both.
Thank you. There's definitely hope. I will say that, definitely.